Welcome to this seminar for the Centre for Personalised Medicine. Anton, it's the first in-person Centre for Personalised Medicine or CPM event here for a few years, so it's really lovely to be part of it. I'm Rachel Horton, I'm one of the Junior Research Fellows at the CPM. And just to introduce the CPM a little for people who might not have heard of it before, it's a communication, engagement and research initiative that's a joint venture between the Wellcome Centre for Human Genetics and St Anne's College. And it's basically a place to have and to progress conversations about the many different facets of personalised medicine. And to that end, we do events like this, and there's also lots of things on our website, like a vlog series where Catherine Wood, one of the other JRFs, has interviewed people about their take on personalised medicine. We've got a podcast where we launched the first episode of the latest series last week, and we do kind of schools outreach event, and there's animations and things, so please do check out our website at cpm.well.ox.ac.uk or follow us on Twitter at CPM Oxford to find out more. Today we're so excited to welcome Danya and Chris while they're here in the UK. Dr. Chris Gyngell is a team leader in biomedical ethics at the Murdoch Children's Research Institute and a senior lecturer in the Department of Paediatrics at the University of Melbourne and a senior research fellow at Melbourne Law School. Dr. Danya Vears is a social scientist with a genetic counselling background. She's a senior research fellow and team leader at the Biomedical Ethics Research Group, Murdoch's Children's Research Institute, and holds honorary positions at the University of Melbourne and as a guest professor at the Centre for Biomedical Ethics and Law at KU Leuven. And today they're really kindly speaking to us about their research exploring ethical aspects of the introduction of genomic technology. So thank you so much for talking to us today.
Thanks very much, Rachel, and thank you everyone for being here. It's really great to be presenting in Oxford again. So I'm going to be talking to you about some of the work our group's been doing in relation to the ethical issues raised by genomic sequencing in a very specific context, and that's genomic sequencing of critically ill children. So genetic disorders are the most common cause of admissions into neonatal intensive care units, the most common cause of making children really, really sick very early on. And it's not surprising then that we've seen the introduction of sort of next generation sequencing technologies like whole exome and whole genome sequencing really improve care for this patient group. You see benefits for the patients themselves, the children themselves. Every once, not very rarely, but sometimes genetic sequence will figure out the cause of a child's illness, and sometimes it can point to very, very simple treatments. Sometimes it can point to a disorder of metabolism, and it's just you're not producing an amino acid or something, and that can be, fixed by a specialised diet. So in some cases, it can be life-saving for these children. In other cases, it benefits them by ruling out different other diagnoses and then sort of redirecting care in a more sort of personalised way and avoiding sort of invasive tests and things. It's better for the families, for the parents of these children, because often they've got to make these really high stakes decisions, and it's good to have as much information about the diagnosis and about the outlook as possible to make those decisions. And it's also good for the health system in general. So although genomic sequencing is an expensive test, it's an expensive technique, studies have now shown that the money that you invest in these sequencing technologies in this cohort, you get back in other, you recoup the money in other things by saving money on other sort of tests that are doing. And also because the actual NICU beds themselves are such a resource intensive sort of care thing, if you can effectively sort of manage time on there, you save a lot of resources. So it's all been, a very good sort of so far. It's been a good introduction of this technology into this setting. But the real throwback, or the sort of the drawback, has been the turnaround time of 3 to 6 months for a standard next generation test. And this obviously is limiting its applicability to this group. Often these children are sick and they need treatment much sooner. So what we've seen in the past sort of 5 or 6 years is a new sort of groups of sort of technologies or sort of programs that focus on rapid genomic sequencing. And this has incredibly increased the speed at which it takes to get a genomic sequencing from months to hours or to days. When we first started looking at some of this work, there were really only 2 groups that were doing this rapid sequencing. There was our group in Melbourne and there was another group in San Diego. Since then, I know there's other places around the world that are starting to do it. With this type of technology, we've seen the world record of a genome sequence in 5 hours and standard turnaround time in a matter of days. We see that this really amplifies the benefits for critically ill children. You get diagnoses faster, you'll get a higher proportion of really life-saving treatments for some of these children. And the sort of figures in these early studies, really bear that out, that there's a diagnostic yield of 50% of cases, so they can diagnose around 50% of the critically ill children who are sequenced with this rapid test. And a change of management has occurred in around 60% of cases. Because of these really clear benefits that you see in terms of the diagnostic rate, there have been calls for this to be a sort of first-line test for children in NICUs, for critically ill children. So as soon as a child is sick, the idea is that you would sequence them sort of straight away. So our group that we worked with some of the clinicians doing this, and basically we identified that before this became a first-line test, this technology really raises a number of sort of ethical issues that need to be thought through carefully before its sort of great expansion. So we've put together sort of a grant application to sort of look at these issues. As I said, we're working with some of the clinicians at Melbourne who deliver these tests to children. We also work with some lawyers and health economists at Melbourne. And we're sort of investigating the sort of, I guess, 4 different dimensions. The first dimension is the effect on caregiver-child bonding. So we know that the first few hours and days after birth are a really important time for bonding. It's an important time of a sort of amazing neuronal growth going on in the infant. What we're seeing with some of these technologies is that if you're delivering a genetic diagnosis, and sometimes a sort of complex diagnosis, a diagnosis that people might not have heard of before, there's a real worry that this could interfere with the bonding process and have negative effects for the relationship and for the child going forward. There was sort of anecdotal evidence of some of this happening with these rapid tests. The clinicians became alarmed that a number of parents would get a result that said, their child has a lifelong genetic disability, and they were then perhaps relinquishing care of that child more so than they would have done, and also sometimes deciding against potentially life-saving treatments, so withdrawing care. And this alarmed some of the clinicians. And the thought was, if we go back to the standard genomic testing, whether it's 3 and 6 months, you are sort of then delivering a diagnosis in a more sort of established relationship. And perhaps that's an easier time to bear if you're going to get a diagnosis then very, very early on before you've had a chance to bond. So some of the work we've been doing in sort of that aspect is talking to some of the parents about it and looking at the effect of a diagnosis on things like family functioning going forward. It can also be a strain on clinicians, and what I mean is it can make decision-making for clinicians really, really tricky in some of these scenarios. So obviously, generally, more information is good information, but there are limits to that, and sometimes the rapid genomic sequence will give you a diagnosis, but there's huge variability in what that diagnosis means for the child, and maybe you're making decisions based on 1, 2, or 3 other cases in the world. So it's a strain on clinicians, and part of the work we've been doing is doing focus groups with clinicians who have been delivering this technology to help understand the sort of challenges that they're facing. Questions also arise about what you do with the data that's generated, the sequence data. Danya's going to be speaking a bit about that in her talk, but part of the work that we've been doing is talking to some members of the public to see what they think about that. And finally, informed consent. How do you get consent for this very important, very complex test? And that's what I'll sort of focus on for the rest of my talk, that question of informed consent. So in this setting, there's a sort of a number of factors that make informed consent really, really tricky. And in fact, it's nearly like a perfect storm of difficult factors. So the first is just the setting, the environment that people are in. You're in a neonatal intensive care unit, your child's obviously very, very sick, and you're not going to be in a state where you're going to be able to take on information and reflect on it and make informed decisions. So I know this from some personal experience. My son was in a neonatal care unit for just 1 day, but by the time we got in there, I was sleep deprived. I hadn't slept for 4 or 5 days. I was incredibly stressed, and I could not remember the conversation I had with the doctor. It's just not a state to be in where you're going to be absorbing information and being able to reflect on it critically. But in addition to this, genomic sequencing is a really, really complex test. If you haven't heard of it before, if you're sort of a general member of the public, it's going to be confusing, what they're actually doing. But apart from that, there's just so many potential outcomes that could come from the test that it's really, really hard to make these decisions. And in addition, the setting of the NICU, often these decisions need to be made quickly. It's part of the thing that you need to make treatments decisions. So there's going to be pressure on people too to make a quick decision. And given the high utility of this test, you can imagine that there's sometimes going to be pressure on parents to consent to the test quickly because they think it's such a high yield test. So as these sort of technologies move from being in a more research setting, if they are going to move to a frontline test, there's a number of really difficult questions, I think, that we need to analyse. And they're already sort of occurring in the sort of settings where they're being offered. One is, is going to be verbal or implied consent, is that ever ethically justified in this particular setting for RGS? Normally you would get written sort of consent and have pre-test counselling and things before you consent to a genomic test. Are there going to be any cases in this context where you can go through another approach? Another question which the clinical teams already face is what do you do when parent really wants the test and one parent is actively refusing the test for their children, remembering that the test is going to have implications for sort of all family members in this sense. And what about cases where there's no parent or guardian is available to provide consent? So to sort of think through some of these issues, I'm going to present a case to you. This is a hypothetical case, but it's sort of a combination case based on actually real clinical cases that the clinicians are sort of facing. So Serena developed intractable seizures after 24 hours of birth and was transferred to a neonatal intensive care unit. When she was transferred, her mother began experiencing severe postpartum depression with possible paranoid ideation, and Serena was admitted, and the mother was admitted to a psychiatric unit with postpartum psychosis. After that, Serena's health was deteriorating quite quickly. She's getting sicker and sicker, and the clinical team recommends a rapid genomic sequencing to see if they can find a diagnosis for Serena. They try to arrange consent through Serena's father, because obviously Serena's mother is no longer in a position where she can consent. And the father urgently preoccupied with his wife's hospital admission and caring for the other children. So in this case, Serena's father provides verbal consent. He sort of says something, look, do whatever you can, do whatever you need to do, whatever tests, I provide consent to it. However, he was unable to actually come into the hospital and set aside time for pre-test counselling. So as Serena is getting sicker, the doctor, the intended neurologist in this case, who's Dr. G, it's just a fictional name, has to make a decision. Do you do this test with this really, really sick person now, knowing that you've got a good chance of being able to find a diagnosis if you do this test, or do you wait for written consent for one of the parents to be available for pre-test counselling to get written consent to this test? So those are the sort of two options. I'll just talk about some of the considerations sort of in favour of each option. So essentially, with this type of test, without pre-test counselling, Serena's father's consent is not going to be informed consent. He is not going to have all the information. He's not going to be able to sort of reflect on all the possible implications for their family, for themselves, and for Serena's, for the implications for Serena's health as well. So we know that genomic information has implications for family members. It will have implications for their other children. It could have long-term insurance implications for all their family. And we normally think people need to be aware of these types of implications before you can make an informed decision to have a test like this. And in addition, another sort of unique thing about genomic testing as opposed to a lot of testing that gets done in sort of critical care is they can reveal more information than about the than the condition itself. So Serena's obviously having seizures, and that's the main concern for health at this time, but it could reveal all types of other sort of long-term health impacts for Serena, and the family need to be prepared for that type of information to come out. But on the flip side, it seems like rapid genomic sequencing is clearly in Serena's best interest in this case. And I say that because it seems Serena's health is deteriorating, she's a critically ill child, and she's dying. It seems like the disunity of death and dying really swamps a lot of these other considerations here. And in a sort of, in a common sort of obligation sense, you think doctors need to act quickly to try to save the life of the children under their care. And if test is able to do this, then that seems like a reason in favour of it. In addition to this, we need to be sometimes careful that are we treating this test very differently because it's a genetic test? There are other types of risky tests that they might do in critical care, such as a spinal tap. A spinal tap is physically risky. There's sometimes a chance of paralysis that you do. It's a small chance, but there's a chance. Often doctors in different parts, and I'm mainly talking to Australian critical care doctors, so have that perspective, but they won't get written consent for a spinal tap. They will just do a spinal tap and they will get verbal or implied consent from it. Similar for MRIs. MRIs aren't as physical risky, but you can get incidental findings on MRIs in these things. You could find, different shadows in the brain or something that you weren't looking for before. So there's this sense that, well, are we just treating this test very differently because it's a genetic test, a sort of genetic exceptionalism kind of thing. Another interesting thing I think about the consent for this is that you might think that it's nearly enough that it's in Serena's best interest, that the father's verbal consent would be sufficient. And what I mean here is that, often when, an individual is consenting to a test for themselves, they're free to think about their own values and think about how they want to live their life and make a decision that accords to that. But this isn't a case where you're getting someone to consent for themselves. You're asking Serena's father to consent for Serena. So she's meant to be consenting for his child. And in that sense, it's a sort of in a proxy decision-making. The decision-making is meant to be simply just meant to consider not your own personal values, but what's in Serena's best interest. And if you think that because she is dying in this case, it's clearly in her interest to get a test, you might think that the function of really Serena's father's consent here just collapses into the best interest kind of test. And another thing about this case that you might think, although the father, he can't make an informed decision to have this test and he doesn't have all the relevant information, but maybe he has enough information to make a robust decision. And I'm saying this from a sort of personal perspective. If I put myself in the father's shoes in this case, I would think, look, I know I don't know anything, but I know enough. If it's going to help my daughter, that's all I need to know at this point. And please just do it as quickly as possible. So I think this is a very hard situation. Now, what will happen legally in Australia is they will always wait. They nearly always wait for written consent in these cases because there's very clear legal guidelines around regulations in Australia, and I imagine a lot of places that you need written consent for a test like this. And one of the things we've written our paper, with Danya as an author on this paper as well, sort of asking whether this is right and whether maybe we need to reform some of the guidelines that govern genomic sequencing in this test. So I've got some of the major Australian guidelines up there. But basically what they require is that you need to have written consent for a genomic sequence if it's a complex test. And the type of complexity is how many genes are you looking for? If it's lots of genes, then you need a thing. And you're looking for lots of sort of genes in this sort of case. But we think ethically, it's not just complexity that should make a difference to what types of consent that you look for. RGS presents a really different setting to other types of genetic sequence in that it's sort of time sensitive. You're in this sort of setting where people are dying, they're much sicker than average, and time can be of the essence. So delays in consent can have bigger negative effects for this cohort than delays related to consent in other genomic sequencing settings. So, our sort of take when we're looking at this is that we think these regulations should be more flexible. They should give more options for sometimes implied consent to be valid in these sort of cases, or verbal consent. But obviously, I think that's flexibility. That's not going to be the same for any parent. And obviously, when you can do pre-test counselling, that's always going to be preferable to situations where you can't. That's the main sort of talk. I'll say, although the case I presented was one where it was a postnatal depression, and that was sort of leading up to a case. Another common case where they won't have a parent to consent is where there's not an interpreter available, and it's to children who don't have English as not their first language. So in these cases, you will often get parents who might sort of give all the indications that they're happy to have the test and they want to do everything, but they can't provide informed consent because there's not an interpreter. And the question then becomes, how long do you wait for the interpreter to come? What if it's a few days and the child's health is at risk? Would this be another sort of case where it would be okay to do a test like this without written consent? So that's all for me. So that was a sort of informed consent kind of element of this sort of thing. And Danya is going to be speaking a bit more about some of the data governance things now. Thank you.
Great. So thanks, Chris, for leading us up to this point. As Chris mentioned, I'm going to be doing presenting to you some information about some focus groups that I did with my colleague, Fiona Lynch, where we actually spoke to members of the general public about their perspectives on data sharing and data storage. So why is it important to store and share data? Well, in my opinion, it's critical to the future of genomic medicine. So one of the problems that we have in genomic medicine is that we have a lot of variants of uncertain significance that are identified these days. And that basically means that we find a variant in a patient who has a genetic condition and we can't classify it as either benign or pathogenic. So it's sort of in a middle ground area. And that's not particularly helpful. It's not particularly helpful for clinicians because they don't really know what to do with that. But it's also not helpful for patients because it doesn't provide them with an answer. Data sharing and data storage is a way that we can help solve that problem. If we do have more data on databases that can be accessed by clinicians and laboratory scientists, then we're going to be increasing the chance of diagnosis, both for current patients and future patients. It's also going to help clinical research because we can help identify different genetic causes for new disorders, etc. One of the issues at the moment as well that we have in the genomics world is that the current databases are very full of people of European ancestry. So there's about 70% of all the genomes that have been sequenced to date around the world are from people of ancestry that is European. So we need a lot more diversity. We need that to help improve healthcare for all the different populations. We also need larger data sets because in general, a lot of the genomes that have been stored are in things like rare disease and cancer. But now we're going to be using this information for more complex disorders like hereditary cardiac conditions and diabetes and things like that. So we need more data to be able to inform our diagnoses of those conditions and help find the genetic causes. But there are some challenges associated with data storage and data sharing. So we need to think about a whole range of different issues. We need to think a bit about what types of data should be stored and shared. So should we just be storing the variants that are identified, those little changes in the DNA that might be the cause or might not be the cause? That's just one piece of information, but it's actually not that useful unless we have clinical data associated with it to help inform what that means for that patient. But then as soon as you start introducing clinical data, things become a lot more identifiable. So you might have a variant that's identified in a patient, but that patient has a genetic disorder. There's only like 9 people in the whole world that have that. So as soon as you start associating the clinical data with it, it makes it a lot more identifiable for that patient. We need to think about where the data is stored. So do we put it all in a centralised repository where there's one governing body that makes all the regulation around it and the security issues are taken care of by them, which helps accessibility? Or do we decentralise it? So we put all of the different data in, like it's all held by different organisations. So each research institute or hospital has their own data. So that all these decisions have issues for security as well and accessibility. And we need to think about who has access to that. So should it just be hospitals and medical professionals, or should it be researchers as well? What about other entities like government bodies, pharmaceutical companies, etc.? And how do you regulate access? How do you make sure that the people who are accessing the data that we have stored in these databases are bona fide researchers or hospitals and not just random people trying to access the data for malicious purposes? And on top of this sits the idea of informed consent. So how do we make sure that the people who are donating their data are making informed choices about what's done with it? And how do you maintain that over time? So we were really interested to find out what the Australian public thought about all of these issues. So our aim was then to explore public perspectives of a few different things. So we wanted to think about the benefits and the concerns that they had around data storage and data sharing. We wanted to ask them about the access issue and how they felt about who should access it. We asked them some questions about logistics, where it should be stored, how it should be stored, and then there was quite a lot of questions around data ownership and control of that data. And the context we gave was the one that we've just talked about in Chris's talk, which is we basically presented them with a scenario that we said, okay, you've got a child who's got a genetic condition, they have DNA sequencing performed trying to identify the cause of that genomic condition, but then what do you do with the data afterwards? How do you make the most of it, or do you destroy it? So that was the setting that we gave them. So we recruited via Facebook, which was really fun. Through the Murdoch Children's Research Institute, we did some advertising. So it went out to, I think, everyone in Australia, as far as I'm aware. And we had like hundreds of people register. So there was a link associated with it where they could go to our website and put in their details to be contacted to participate. And we had about 300 people who said they were willing to be participants. Obviously, then we screened for eligibility because we wanted to make sure that they were over 18 and therefore eligible for the study. But we also wanted to try and actively get people involved from a diverse range of perspectives. So we wanted a range of different ages. We wanted people who lived rurally and in the cities, and trying to get representation around a bunch of different states. And then I created a video about data storage and data sharing, which was kind of fun. I've never done a YouTube video before, it's my first time. But I put together this video that basically gave them some information about what data storage and data sharing was and some of the issues around it for both positives and negatives, so that they came in primed, because I think it's all very good and well to sort of get people on board and say, like, let's talk about these issues. But if they don't know what the issues are to begin with, they're not really coming in with the most informed perspective. So we conducted focus groups. We did 7 of them, and they all lasted an hour and a half. And we recorded those and transcribed them. And then myself and my colleague Fiona Lynch, who was also doing the focus groups with me, we analysed the data using inductive content analysis. And one cool thing that we did as part of the focus group at the end was that we used this Mentimeter app where we actually got people to rate. So we pulled all of their characteristics out that they were talking about during the focus groups, and then we presented them to them at the end, and we said, okay, you get 100 points. They're in lots of 10, and you get to allocate which ones you think are more important. And that's an interesting way to see what people value, but we're using that to inform some discrete choice experiments that are being done at the moment. So you can see from this massive table that we had 7 focus groups and 39 participants in the end. And the age range was quite good. So we got the people were all between 18 and 67 years of age. We got representation from 4 of the states in Australia. And we did get some people from rural areas as well, which was really important. We got people who did and didn't have children. We had quite a few people who were born in countries other than Australia, and you can see there a large proportion also spoke a language other than English. So it didn't necessarily have to be their first language, but we wanted to get that perspective as well. And not quite as many men as we would like, but we got some, and that's a good start. So I'm going to present some information on 5 of the different categories, sorry, that we discussed in the focus groups. So just generally on their overall perspectives of data storage, they were generally overall quite supportive of genomic data being stored. And they were comfortable with the reuse of that data to benefit the wider community, provided consent was obtained from the donors. So as this participant said, I definitely think with appropriate permissions that the data should be stored. But not everyone felt that way, and there were some people who were a little bit on the fence, and some people felt it wasn't an easy yes or no answer, and that it really depended on what the purpose of that data storage was. So as this person said, it depends on the context of why the data is being collected. What are the potential benefits of saving the data? I don't think it's a black and white issue, like every genomic sequence should be saved. They highlighted a range of benefits associated with this data storage and sharing, and there was this general sense that the benefits outweighed any potential risks. So as this participant said, this information is just so valuable and helpful. Who knows the ways we're going to be able to use it in the future? And the benefits that they talked about were in relation to both individual and also population health. They raised issues around improved disease identification, treatment, prediction and prevention. They talked about pharmaceutical companies being able to develop medications from the information. And then they talked about this collaborative endeavour that could happen between research institutions by that sharing. So as this person said, sometimes storing the data can be very useful also in terms of research and development for some medication or other sorts of treatment. But there were some concerns raised, and some people felt that the data could be used for malicious purposes, and that was a real worry. So they were concerned it could lead to things like discrimination and disadvantage. They were worried about institutions using it for personal financial gain, and they were really concerned about a loss of trust in different organisations. So as this person said, if the data gets into the wrong hands, it could end up being very bad. Some people, if they're not very moral, they can just sell your data to a third-party company, and the customers who have their data, they will feel very angry at them, and obviously it would break the trust between them. And there were quite a lot of data privacy and security concerns raised by the participants. So this person said, regarding the safety of the genetic data, I think this is really critical as well, because we need to make sure that the regulation of storage of genetic data is very robust before we really encourage people to let their genetic data be collected and stored. The access issue was a massive one, so we're going to talk about that for a little while. There was generally a lot of benefit seen with sharing with health professionals, and they felt that this should happen automatically because time is of the essence for healthcare. So as this participant said, might be stating the obvious, but your doctors and your specialists should have immediate access to it. It should be readily available and quickly. But they were also quite positive about sharing with researchers. And they recognised that this could be difficult for researchers to access, but they viewed that researchers provide a service to society, so they felt that they were not really in it for personal gain, and whether that's the case or not is up for debate. We can maybe talk about that a bit later. But this person said, in principle, my view is unis, hospitals, organisations that exist in our society, ultimately for the greater good. How I view sharing my data with them, I'm a lot more open because they don't exist to make a profit for their shareholders. And we talked a bit about sharing with family members, and so some people felt that because there is so much benefit that could be gained by sharing the genomic data with family members, it should be automatic. But others felt that privacy should be protected, and so that shouldn't be the case. And then some people felt that sharing might be useless. And as this person said, if my relative wants my genetic data for some implicit reasons, I personally would not be very comfortable because I don't think most people have that information. Or knowledge to directly read the genomic data and know what that means. So I think in their view, the sharing would happen with the family member directly rather than through the health professional. But generally, there was a sort of an overall consensus that if you are going to share with family members, consent should be sought for that. So as this person said, I think it's probably more flexible to require consent because different families have different circumstances. So if that is in place, it's more flexible and more inclusive to different people's needs. There was quite a lot of concern about sharing with employers and discrimination issues. So as this person said, I guess we're dealing with diseases and illnesses and mental health issues, etc., which is really, really sensitive. And there's still a lot of discrimination and stigma and shame that stems from that. So if it got into the wrong hands, I think it would be potentially very individually quite confronting and potentially damaging. Like, does an employer have access to it? I think there's a lot of risk there. Pharmaceutical companies was an interesting one. So there were definitely some concerns associated with sharing with pharmaceutical companies. People generally had quite a lot of lacking of trust in these sort of private and profit-driven entities. So as this person said, in the case of pharmaceutical companies, I think they've rightly got most people's distrust. There's been ample, very recent examples of where they've done the wrong thing by people. They've made data suit their outcomes, so they get drug approval where it might not be warranted for off-label uses. Blockbuster drugs where they don't necessarily need to be used. So I think people have come to distrust pharmaceutical companies because they're largely profit-driven MO. But there was a recognition that they also do things that can benefit society. So without them, we wouldn't have new medications coming out for some of these rare conditions and other treatments. So as this person said, I think in a general sense, I'm nervous about anyone that can profit using that information, that can profit financially. I've also been very impressed when there's a particular drug that's developed where there isn't a patent on it and it's cheaper and it's more accessible. So for me, I sort of go, well, that's more concern about health than profit. Whereas when certain medications with patents on it, or like all kinds of things, and it sort of starts to come across as being more profit than health, then there's a concern. So this idea about profit being an issue is really coming out in these focus groups. And then we talked about insurance companies, and there was a general sense that sharing with insurance companies would negatively impact the data donors. So this person said, because the insurance company's access would directly impact the individuals financially, because they may want to, it's just too sensitive, that will make you be excluded from claiming some compensation or whatever. So I think that direct financial impact on the original owner of the data is really preventing the sharing to the insurance companies. Again, there was a lot of distrust because businesses are not necessarily known for their altruistic behaviours. And there was a lot of concern about discrimination in offering and costing policies. So I guess it's because a lot of the people who are having their genome sequenced already have health issues, so there's a lot of discrimination there. So this person said, I can't really think of any advantages to sharing with insurance companies. I think they would just love to get their hands on that information, and there would be discrimination, and for so many people it would be very hard to be insured, so I can't think of a reason to do that. But some people did recognise there might be benefits to some people from sharing with insurance companies. So insurance premiums could be tailored to those who actually need more cover, would have to pay more. And they felt that there could be some stability for the wider insurance company. But interestingly, people who were raising these ideas didn't necessarily agree with them personally. So this person said, I can see how the argument might be, okay, well, if we incorporate some of this information to our health insurance premiums or whatever, then people who don't have any underlying genetic condition can get cheaper health insurance. But I could see how that would be the argument, and I think that's absolutely ridiculous. And then we talked about like the law enforcement agencies and governments. And some people felt that automatic sharing should happen with these enforcement agencies without consent. So this person said, it should be automatic because this is something that is against the moral values of society. And so the consent for this sort of data access or access of this data is not necessary at that point in time. But others felt that wasn't appropriate. So there were concerns about equity. So again, like the people who are having their data sequence obtained and shared, they have medical conditions, so they felt that they would be further disadvantaged by this sort of sharing. As I mentioned at the start, the context that we gave people was with children who are sharing their data. So because the children aren't consenting for themselves, they thought this would be problematic. And they also were concerns that if this happened automatically, then people might be deterred from sharing their data. So this person said, I think that the idea of that access would be enough to put so many people off. People are so concerned about this idea that they'll be tracked and traced by the police that this will come back to bite them. That risk of deterring people participating outweighs any benefit that you might get. So lastly, I want to just touch on some data ownership issues and control. So we talked a bit about who should store the data, and the participants felt that the government was the most obvious option. So this person said, hopefully it can be managed by government or something like that, so it's not private. Again, this like private profit connection. But others were really wary of government bodies being in charge. So this person said, I think there's been numerous occasions where the government has failed to properly protect our data, and I think I'd be more wary about genomic data storage if I knew the government was in charge. Some people thought that research institutes should store the data, again, because we're apparently less money focused. So this person said, I think that it should be held in control of something like the Murdoch Children's Research Institute, rather than a third-party body who would be more interested in the money side of it. So I think it needs to be held by a responsible body who would literally be there for the genetics and not as a business. And people talked about this organisational trust as a really important factor. So this person said, I would be less trusting of, say, a government health system versus a private organisation, because I would be questioning whether the private organisation is for profit and whether that is going to influence what they do with the data. And then we talked about consent. And so in the video I did, I talked a bit about what broad versus specific consent was, so they had some ideas. And they really talked about the limitations and benefits of those. And so it was generally considered that broad consent was more convenient for researchers, so there was a benefit there. But the participants generally felt that specific consent was much more of an attractive option for them. So this person said, I think that regaining consent every time the data is shared is really important for me personally. I'd like to be contacted every time because you just would want to know where your data was going. Someone had ready access to information about their data, so what was happening with it on like a day-to-day basis. And this idea of maintaining control over the data usage was really prominent. And the dynamic consent model was favoured by a lot of the participants. So as this person said, I think that it would be good to have it being able to change at any time, like because you might have different opinions in the future because people's thoughts keep changing. And because of the possibility of using online platforms, people thought that this should be pretty easy to accommodate. So as this person said, if it is one of these online systems where, yeah, I think that would be great for convenience, that you can just log in and say, I don't wish to share this, or these are the specific people I want to share with, or even if you do want the data to then be destroyed. But there was a recognition that obtaining specific consent every time you wanted to use the data for something different might be burdensome for the researchers and a barrier to research actually being enacted. So as this person said, are we also going to read the individual research proposals that are going to happen with our genetic data? Because how many of us read the terms and conditions when our phones are updated? If we had something like that, 40 pages long, come through each time, are we going to read it every single time if we see like 20 of those a week? So there was a suggestion that if you were going to get reconsent, it should only be used for new uses or if policies change around the use of the data. So this person said, I think for convenience, it's probably better to have a preset consent for a list of trusted uses. However, if there are uses outside of that list or outside of the scope of the purpose, then I don't mind to get to consent separately, but I wouldn't think it's convenient to consent too frequently. But others said, yeah, like I'm happy to be recontacted as long as it's not too often. So this person said, to have to provide consent every single time would be a hassle if it's frequent access, but if it's like once a year or once every couple of years, then it's not such a concern. So I guess this idea about how often the data is being used was really important. Importantly, people's decisions about data storage and sharing should be informed. And they said, I think that when you're trying to store data, you should be telling them about the benefits and the risks and allowing them to have that information before they make that decision. And again, consent should be explicit. So that we talked a bit about like opt-in versus opt-out, and they felt that opt-out should be, shouldn't be the default. You should have to choose. So this person said, whether the consent is opt-in or implied, I would err on the side of opt-in because it seems to me to lend itself most naturally to the most informed consent rather than the assumption that this is just part of the process of the treatment of the child or whatever. But I think when you have opt-in consent, it sort of stops the parents and makes them, not forces them, but encourages them to consider more deeply and understand more about the steps that are involved in their child's treatment or whatever is happening with the child. So just to sum up all of that, what I really learned from this study was that it's really difficult to develop a one-size-fits-all approach when you're talking about data storage and data sharing, even just in Australia, let alone worldwide. We found that participants were generally in favour of storage data, but it really mattered what it was being used for, and they wanted to know and wanted to be able to choose. The sharing with health professionals and researchers was generally accepted, but there was a lot less trust in pharmaceutical companies, insurance companies, and government. But there was quite a lot of conflicting views on who should share this and store and take responsibility for that data. And as I mentioned, organisational trust was seen as really important for these participants. And control and consent were really key things that came up. I guess one of the things that really struck me was that people had what is probably quite unrealistic views about how often they would be asked about their data being shared with different organisations. And I think we need to do more work to sort of get what's acceptable versus what people's expectations and desires are. So I think even more of a deliberative approach would be appropriate to sort of get to the nitty-gritty about that. So thank you. There's my collaborators, including Chris.